Mike Gibson and Alan Taylor here. We're talking about understanding the angiographic CT angiographic assessment of athero, including plaque analysis. You know, a lot of people out there, like you and I, Alan, they go and get a calcium score, but it's a little confusing to everyone. What's the difference between three things: a calcium score, a CT angio, and plaque analysis? Walk us through that.
If you're already talking calcium scoring, you're one step ahead because you've left risk scoring behind and said
Yeah.
we need to move to a disease model where I need to know disease. Cardiology, we have too many tools to work in guesswork anymore. So this moves us into a disease model. So if you're doing calcium scoring, you're doing a non-contrast CT for the calcified plaque that bears an overall relationship to the overall plaque burden a patient has and incrementally identifies risk and can guide therapeutic intensification.
It identifies risk over and above some of those risk models that we already have, right?
Perform the same in terms of discrimination, and they get about half the population wrong. Over treatment, under treatment, and they are horseshoes in a world where we don't have to play horseshoes anymore. If calcium score gets a B, CT angiography for plaque gets an A. It's about, do you have disease? And CT angiography is currently indicated for symptomatic patients. We're not into asymptomatic screening as of yet, Mike. However, once you do that, you see overall atherosclerosis in its totality in the coronary arteries. All plaque components, total plaque, calcified, non-calcified, and it's the non-calcified plaque, which is really driving events, is modifiable and is what calcium scoring doesn't see. Plaque analysis is now brought to scale through Heartflow's AI technology, which it makes it very fast and reproducibly accurate to measure total plaque volume, which now you're looking at a test which is telling you the totality of disease, the portion of non-calcified plaque. So again, you're not working in guesswork anymore. You know exactly, you can stage disease. So not just do you have disease, but now it's you have stage 1, 2, 3, or 4 disease, much like an oncologist does. You just don't have breast cancer. You have stage 1, 2, 3, or 4 breast cancer, and that determines treatment. So we're really moving it from into a disease model and then into a refined disease model so that treatments, at the end of the day, it's all about the treatment. The treatments can be optimized.
Is there a way you can quickly tell us what stage one, two, three, four is?
There is a proposed staging system which goes by total plaque volume. Valentin Fuster said publicly as well that total plaque volume is the single best driver of risk. And it's all about extent. So stage one would be by total plaque volume in the coronary arteries, a level below 100 cubic millimeters, stage two up to 250 cubic millimeters, stage three up to 750, and stage four above or severe extensive beyond 750 cubic millimeters. And this is how Heartflow AI plaque analysis quantifies the plaque by volume of plaque in the coronary arteries.
Now, volume of plaque, but talk to me about the type of plaque, soft plaque versus hard plaque. Does that add additional prognostic information?
It does. So that's going from the calcium scoring to total plaque. And there is incremental value and a lot of net reclassification index enhancement by moving from just calcified portion to the total portion, because there's a close but not a one-to-one relationship. Once you look at all the plaque, Mike, you can then actually look at its analytics even beyond just plaque. You can look at high-risk features. One common high-risk feature that's written about is what we call low attenuation plaque. These are non-calcified plaques, which have very low density. And so they're felt to be more necrotic areas, inflammatory elements, as opposed to other non-calcified plaques, which may be more stable, not a thin cap fiber atheroma that's most likely to rupture. You can then even go beyond that. And the most recent models actually look at other elements around the coronary, like fat around the coronary artery, which is an inflammatory marker. So you're suddenly going to look at sort of the totality of atherosclerosis, its phenotype, including subtypes of the phenotype, and associated variables like inflammation, which together create risk, well beyond a calcium score. So a calcium score gets a solid B, but we're really in this area of now advanced analytics for coronary atherosclerosis.
And how far are we along in looking at that periarterial fat? That's kind of an A plus if we know that, right? And does it help discriminate further, or is it just additional information?
Meta-analysis just published this month in JACC Cardiovascular Imaging does just this. It looks to the totality of all of these different measures and really shows that each is incremental so that, we're going to, in a future state, which is why we need to move beyond. I mean, risk is way in the past. Calcium scoring brought us into the atherosclerosis age. And now, as the Lancet Commission urges us to move into this area of, atherosclerosis, coronary artery disease detection at earlier ages, we move into this totality of the of atherosclerosis, both how much you have, its subtypes. So it's really getting quite sophisticated to find patients at the highest risk. And then we launch into full prevention mode. And if you think of all the novel and even costly treatments coming down the pike, which we want to use, but we want to use them in the right patients. And that's what CT affords us, this ability to refine the treatment population. And what the data show is we actually get the right people treated. We actually treat fewer people, but treat the fewer people that are treated better.
Okay, so that's the anatomic assessment. I am a interventional cardiologist. I'm also a guy who's obsessed with coronary blood flow, having invented the frame count. What value does then the FFR bring to the anatomic assessment? Does it add additional value in terms of risk assessment?
Dealing with let's start with the symptomatic patient. And it's a class 1A indication to do a CT as a first assessment in the evaluation of chest pain. It actually has a higher level of evidence rating than traditional methods such as stress testing. You do a CT, you find an intermediate lesion. FFR CT is the next step to clear obstruction versus not obstruction. And we know from clinical trials there is that patients that get that FFR CT, we get the right people in the cath lab. And this is optimization of resources. We treat, we cap the same number of people, but we get the right people. We're getting the people that have disease. It actually has greater yield on the revascularization side. And as we all know, FFRCT guides appropriate revascularization from an outcomes perspective. But even beyond that, then knowing how much plaque somebody has, and this is a departure for many cardiologists thinking, oh, once we have disease, we treat them all the same. We know what they have. And this is a fallacy. The more disease you have, the more risk you are. And we've known this forever. Just think in the context, and if I said to you, Mike, tell me, does a patient with one vessel disease do better than two vessel disease and three vessel disease or three vessel plus left main? And you go, absolutely. Disease extent matters. But now we're using CT for disease extent on top of presence or absence of obstruction. And even in the absence of obstruction or in the presence of obstruction, atherosclerosis extent matters. So we're really getting to refine risk, even in those with known disease. And the models would tell us that it helps across that entire spectrum of patient. And that's why CMS is basically saying, we're going to pay for this in people with, up to 70% stenosis. We'll pay for this. We'll tell you about atherosclerosis extent because it's greater efficiency in care, both on the cath lab side and on the prevention side.
There is a patient attached to the stent, and even after you put the stent in, there's a lot of disease there, right, Alan? So I think these pictures, personally, had mine done. The pictures are a very powerful motivator and educator for patients to say, yeah, you had that stent put in, but look, there's a lot of other stuff there, right?
A randomized trial going on. You're exactly right. And in Scott Hart, which is a study of ischemia-based testing versus CTA, showed 40% better outcomes in the CTA arm, just because exactly what you're saying. It's the patients were more likely to be treated with preventive therapies, accept those therapies, and live tighter lifestyles. There's a really important ongoing trial now moving into the screening scenario called Scott Hart 2, randomizing to risk scores versus a CTA approach in asymptomatics to basically guide treatment. Early data published from that show exactly this point that we're getting the right people treated. Risk scores are over treating and under treating about half the population, as opposed to really refining it. So it's really, and that's a really necessary trial because right now the guidelines don't support screening asymptomatic patients, even though the data tell us that in that population, total plaque volume is highly important.
So let me ask you this. This is going to be an interesting question. What's the role of a stress test now? I mean, if we can define both anatomy and physiology non-invasively, where do you see stress testing fitting in? I mean, is it in the Smithsonian? I mean, where do we use it?
I think you're I think you're pointing in the direction things are headed. This is the Wayne Gretzky skating to where the puck is going. I think the puck is moving to anatomic assessments for the reasons we're mentioning. It's not just about defining ischemia. And the Lancet Commission from last March said basically that's a model we have to abandon. Waiting to the point a patient has ischemia to start understanding if they've got atherosclerotic coronary artery disease and moving it earlier. And it is more definitive to get, you know, and this has been demonstrated through randomized clinical trials. This idea that you get the right people and you get the right people into invasive angiography and revascularization, which is what we want. We don't want unnecessary invasive testing. Yet then we can go well beyond that with atherosclerosis and really optimally treat them. And stress testing just leaves you, not anywhere close to what you can accomplish with the information value. And really, and people will say, well, what about radiation? What about contrast? What about expense? Radiation levels can be very nominal. Contrast is less and less all the time, particularly the emergence of photon counting CT, lower radiation, more accuracy, and and so you're really getting the right people studied, and the costs, including there's a little more upfront costs, but the downstream costs are actually the same or less. Promise showed us that. Scott Hart showed us that. So the economic arguments kind of fall apart, which is why, frankly, payers pay for CTA these days.
Yeah.
They know that it's economically efficient for them. Then you put on top of that all this prevention opportunity, and it's now going to be done at scale from AI. And you've got all these drugs, not just PCSK9s and GLPs, but lipoprotein little a drugs, other important drugs like ApoC3 drugs, everything that we've got available to us now. We want to get them in the right people. They're important treatments, but they have expense too, and we want to optimize that expense.
Where you said the right people. So we want to give the right patient the right drug at the right dose. But here's the last question I have for you. What about the right time? We know lower is better, but we also suspect, based upon LDL years, cholesterol years, that longer is better, or perhaps earlier is better.
Mhm.
So when is the right time for someone to get that calcium score? When do we start this process?
This is the big question before us. Do we want to wait till disease is extensive? The challenge with calcium scoring is you really have to wait till about age 50 for a man and age 60 for a woman to have it be efficient enough. There's enough to see. You can see it with confidence that you just don't wind up with zero scores you're not sure are going to stay zero. Looking with CTA lets you look earlier in life, so you can catch the non-calcified plaque and those, and you can get people on the right directional course for prevention of atherosclerotic coronary artery disease. And we see this. At the time of MI, half of patients wouldn't even be young patients wouldn't even be recommended a statin by the guidelines. So we're just missing the boat. And this is not a knock on where we've been. It's just a time to it's time to get a smartphone. Leave your flip phone behind. We've got to move into this era because we've got the therapies. Until you have the therapies, it's not worth doing anything. But we've got the therapies now, and we've got the tools, and we have to re-educate a generation of cardiologists to think earlier, and we've got to tool our young physicians to sort of have this really almost like think like an oncologist in a disease model, and get back to atherosclerosis as a disease, not a fait accompli of life, and work to prevent it in the half of patients that will develop it in their lifetime.
Yeah. My son is an oncologist, and he is in his 30s and he is on a statin. Went to his primary care doc, convinced him that lower is better. The LDL years argument that longer is better. So you're right. We got to dump those flip phones, get some smartphones into the thinking of these folks. So really great combo today. Thanks for helping us understand all this better, and thanks to all of you for joining us.